Hello, welcome back. We are moving on to the afternoon session, which is on clinical manifestations. We've got first presenter, who is a close colleague of mine, who is a transplant hepatologist from Cambridge, Dr. William Griffith. He'll be presenting clinical manifestations and patterns of drug-induced liver injury. Over to you, Will.
Okay, well, thank you very much to Guru and the organising committee for asking me to present this first post-break session. So this will be a fairly clinical talk. There won't be too much science, which you've heard a lot of already. I don't have any disclosures. The content of my talk, I'm going to talk about identification of acute DILI and clinical presentation, the biochemical classification. Some of this has been touched on already. A little bit about prognosis in terms of severity of DILI and also in chronic DILI. And then I'm going to talk about some more specific phenotypes with a few case examples. Some of the phenotypes are coming up later in the meeting specifically, so I'm not going to touch on those, and then summarize at the end. So we're talking mainly about idiosyncratic DILI, which is unpredictable as opposed to an intrinsic DILI, such as a predictable injury from paracetamol. Idiosyncratic DILI can range from asymptomatic LFT to acute liver failure in up to 14% of cases in some series. In terms of clinical presentation, it really can mimic any form of hepatic presentation, essentially. Onset is typically a few weeks, but maybe a few days and maybe several months, but we would normally see it within 3 months. And there may be pre-existing liver disease, which could give rise to an acute on chronic picture, decompensated cirrhosis, or perhaps more specifically, acute on chronic liver failure in some cases. So in terms of clinical presentation, we would typically see an acute episode mimicking, if you like, a viral hepatitis or an acute cholestatic syndrome. And in terms of symptoms, these are non-specific, really, and could occur in any form of hepatic presentation: fever, weakness, abdominal pain, jaundice, and in more severe cases, we might see encephalopathy or ascites. We would normally see resolution of the injury once the drug is withdrawn, but occasionally the severity of the presentation is such that acute liver failure occurs, or the injury progresses to a chronic form of DILI. And I'll talk a little bit about chronic DILI, but we are talking about persistent abnormality of liver enzymes with injury, persisting injury evident via histology and or radiology. So in terms of identifying an acute DILI biochemically, and this is an internationally accepted definition from Guru and colleagues from 10 years ago now, and there are other iterations of this if you look, for example, at the US DILIN network. But for the sake of this talk, I'm going to stick with this definition of an ALT above 5 times upper limits of normal, ALK Phos above 2 times, having ruled out bone pathology, or a combination of ALT and bilirubin. And of course, we can see milder reactions, but this is really for definition purposes in terms of trials and research more than anything. In terms of identification of DILI, we also need to factor in enzyme decline following drug cessation and something called causality assessment, which you're going to hear more about later in the meeting, so I won't go into that in detail. I think Marsha's talking on that later. So we have this sort of definition, but we also have a classification, and we know very well that we have these hepatocellular, cholestatic, and mixed types of presentation, where we're using this R value, which is a ratio of the ALT and ALK Phos reference to the upper limit of normal. And this is an example of a cholestatic reaction where you can see on histology that there isn't so much in the way of inflammation, but there are bile plugs consistent with cholestasis. This R value does tend to decline with time from onset. As you can imagine, the ALT will be falling and you may get more of a cholestatic picture. There was some helpful work by the Spanish group showing that gamma-GT is not a helpful enzyme in this classification, but that AST can be used interchangeably with ALT. Now, this is just an algorithm which I've taken from the open access review by the same group. Equally, you could look at the algorithm within the EASL guidelines, but essentially we can see that the R value is incorporated in terms of the defining the pattern of injury, and other aspects of the algorithm are useful clinically in terms of excluding other forms of liver disease, the role of liver biopsy, and really just honing down that this is a diagnosis of DILI. So we have an acute DILI, and we want to know if the patient is going to really run into trouble. So there are a few algorithms that are available to assess this. The sort of historical one, if you like, was this Hy's law from Hyman Zimmerman some years back, looking at a combination of bilirubin and ALT, which in the original study did predict about 10% risk of death. It isn't particularly sensitive and it has fairly low positive predictive value, however. So many patients may reach this threshold and be okay ultimately. An updated version of this includes something called NR, which is new ratio, which includes a determination related to ALT-FOS as well as ALT, and that just gives slightly better positive predictive value. You can also use histological findings to predict severity. So necrosis on the liver biopsy and bile duct loss are more indicative of severe injury, whereas eosinophilia tends to predict more of a resolving injury. There is this TOX-ALF algorithm from Philadelphia group, which incorporates platelets and bilirubin. And when you're dealing with predicting survival and thinking about emergency liver transplantation in more severe forms, the MELD score is useful for that purpose, as well as the King's College criteria. And this is in fact one of the cases that Guru did describe in his talk. Was a shared patient with acute liver failure due to co-amoxiclav, and this is some explant histology showing really severe hepatocyte necrosis. So that's acute severe DILI. In terms of progression towards chronic DILI, there have been different definitions at which point you would say that a DILI is chronic. So historically, 3 months was a sort of cutoff if enzymes remained abnormal. But sort of as we've gone through time, really, we've sort of extended this definition a bit further. So the American definition went to 6 months. There's a UK different definition, which Guru was involved with, looking at a difference between whether it's hepatocellular or mixed in terms of the time frame. And latterly, a 12-month cutoff has been proposed by the Spanish DILI group. There are some specific risks which might predict chronicity, including older age, dyslipidemia. This is very much from the Spanish paper here. Statin use and severity of the acute episode. And from the same study, which had several hundred patients, there were some cutoffs from the second month, which would predict chronic DILI at 12 months, which are to do with bilirubin and alkaline phosphatase. So moving on to DILI phenotypes, we've talked about these classical phenotypes, and we know that most drugs can, in fact, induce any manner of these patterns, but there are some more characteristic signatures. For example, anabolic steroids tend to cause jaundice with relatively preserved ALT and ALT-FOS. Herbs, which we'll hear about later, can cause very high levels of transaminase and hepatocellular injury. Non-steroidals tend to cause hepatocellular injury. And this is in fact a case we published about 8 years ago now, which was the first described acute liver failure due to etodolac. And you can see the biopsy that shows a very severe hepatitis with portal and lobular inflammation. Comoxiclav and azathioprine tend to cause more of a cholestatic picture. And in terms of risk factors for different types of injury, I think we've heard earlier that age tends to associate more with a cholestatic pattern. So moving on to specific phenotypes, I'm going to concentrate on some of these. The ones that I've asterisked will be discussed in more detail later in the meeting, so I'm not going to go into detail on those. And we'll start with the first one, which is hypersensitivity syndromes. Now, we know that there's a variety of immune reactions that can occur with drugs in a very idiosyncratic manner. These are not particularly common, but DRESS, which is drug rash, eosinophilia, systemic symptoms, tends to have liver involvement, and other hypersensitivity syndromes such as Stevens-Johnson syndrome and toxic epidermal necrolysis have been described, and there are typical associations, HLA associations with the drugs that can cause these reactions. So again, this refers back to what Guru was talking about in terms of the peptide binding region, and how the changes within this can lead to susceptibility to various drugs and lead to, as I said, very much an acute immune reaction, one of these sort of hypersensitivity reactions. So that's one type of phenotype that we can see. Moving on to vascular disease, I'll just spend a little bit more time on this. So the first sort of type of pattern that we might see is this sinusoidal obstruction syndrome, which the terminology has changed over the years and was previously called veno-occlusive disease. And in amongst that is nodular regenerative hyperplasia. And these sort of entities, particularly as severe and more subacute, can go on to lead to irreversible disease with portal hypertension and development of complications, varices and ascites. And there are a number of drugs which have been implicated in these syndromes, chiefly chemotherapeutic agents, but also antiretroviral treatment, azathioprine. Just going to show some examples of this. This was a patient who we actually came across only a few weeks ago, 39-year-old man who had been treated for colorectal cancer and had a liver metastasis and was receiving oxaliplatin chemotherapy, and a couple of months in started to develop abdominal pain and swelling and abnormal liver function tests. And this CT scan shows his presentation with heterogeneous enhancing liver on the venous phase and some ascites, and a transjugular biopsy showed quite significant sinusoidal congestion and dilatation, which you can see here. So this was oxaliplatin-induced sinusoidal obstruction syndrome. Fortunately, in this particular case, his liver enzymes normalized and his symptoms resolved and he's currently well. And I think the oncologists are thinking about potentially giving him more of the same. But I guess that's something we could discuss. When the injury becomes a bit more chronic, we see perhaps what was previously described as veno-occlusive disease. So this is a collagen stain, EPSR, and you can see the collagen fibers, particularly around the sort of zone 3 areas. And then on a higher power, you can see the sclerosis of this hepatic venule with collagen deposition around. So very much an occlusion of the small venule here. And this is the other sort of entity that we might see in a situation where there's more of a chronic injury, nodular regenerative hyperplasia. So this could be the aftermath of a veno-occlusive episode, but equally we do sometimes see this occur without that initial acute presentation, more insidiously. And here we have a nodular appearing liver sample, but not because of fibrosis. The nodularity is because we have this alternating thick and thin plates. So we've got these expanded hepatocyte plates and these compressed plates, and this pattern is replicated over the liver and gives this nodular appearance, which in turn can lead to portal hypertension. A rarer vascular phenotype is Peliosis Hepatitis, where we see proliferation of the sinusoids and formation of cysts, which can rupture, and this can be catastrophic. We do see this with anabolic steroids, tamoxifen, and azathioprine. This, in fact, is a patient of mine who had chemotherapy for a seminoma and then developed splenic lesions, the nature of which wasn't certain. His spleen was removed, and histologically there were seen to be these peliosis lesions. And then after that, he started to develop peliosis in his liver. And this is a biopsy showing the irregular dilated sinusoids you see with this condition. I've actually put this chap on sirolimus, which seems to have arrested the peliosis growth, and he's been stable for a few years now, just on 1 milligram of sirolimus. So moving on to biliary disease. We know that rarely we can develop a secondary sclerosing cholangitis with some drugs, typically following a prolonged cholestatic phase. And such drugs are listed here: comoxiclav, amiodarone, atorvastatin, and so on. Just going to describe one case where the drug was not one of these. This was a 24-year-old female who presented with right upper quadrant pain and a history of bladder symptoms. She had this mixed cholestatic picture of liver enzymes, and this was her MRI scan at diagnosis. So MRCP, you can ignore the gallbladder here, but the biliary tree you can see has some dilation with distal stricturing, and then within the intrahepatic ducts there are changes consistent with a cholangiopathy. The history was probed further, and the offending drug was stopped, and a couple of months later enzymes had improved, and the MRCP appearance has improved slightly but not fully normalized. And this was an example of ketamine-induced cholangiopathy, which I've personally seen a few cases now, and I think it may be quite common now, or getting more common. The other type of biliary disease to touch base on is the vanishing bile duct syndrome type of presentation with progressive ductopenia, again following a sort of cholestatic injury. A number of drugs have been implicated in this entity. And this was a vanishing bile duct case that we had due to an alkylating agent, temozolomide, showing portal tracts with absent bile ducts, and this is accentuated using the CK7 stain. So these patients can go on to develop significant pruritus, and with severe duct loss may end up needing liver transplantation. And then the last couple of phenotypes, granulomatous hepatitis. We know what granulomatous lesions look like under the microscope, but just to illustrate them, this sort of mixture of different types of white cell, essentially. And we know a number of drugs that can cause this. Allopurinol is a sort of common one that we see in the UK causing this. And not so much an acute DILI, but worth mentioning, I think, that different types of liver tumour can occur due to drugs. So the oral contraceptive pill is associated with a 10 times adenoma risk and must be stopped in this context. And there are a few other androgens and similar types of hormonal drugs which can lead to adenoma, but also have been associated with malignant tumours. So just to summarize, we've talked about the definition and the classification of DILI and some of the clinical features, some of the patterns. Talked a bit about prognostication in terms of acute liver failure and chronic DILI, and I've discussed some specific phenotypes and tried to relay some of the clinical findings, the histology and the radiology. And I'd like to thank my colleague Sue Davies in Cambridge for helping me with the histopathology there. So thank you for your attention.
Thank you very much. Excellent coverage. I'll leave you to my co-chair to introduce the next set of speakers.
The next speaker. First of all, I also want to thank the speaker. Very, very nice presentation. Our next talk is going to be by Dr. İlker Turan from Izmir, from Turkey. He's going to present, as mentioned, not a case, but a case series. And then Dr. Edmund Aithal will probably speak about a case. But first, let's listen to the case series by İlker Turan, please.
Hello, everyone, dear chairs and participants. I am Dr. Turan from a university in Izmir. First of all, I would like to thank to inviting to me for this excellent meeting. I'm going to talk about our experience ornithazole-related DILI because it seems that ornithazole is one of the most causes of DILI in Turkey. Ornithazole is a synthetic nitroimidazole derivative. It is not approved for the use in US, but used in several European countries such as Spain, Italy, Belgium, and China and some other countries. It is used in treatment of parasitic infections, including giardiasis, trichomonas, and some anaerobic infections. It is usually prescribed for protozoan and anaerobic infection, in especially dental and gynecological practice in Turkey. Only oral formulation is available in Turkey. Ornithazole-related DILI has been reported in some case report and studies so far. Of note, in 2020, it occurred that approximately 1,500,000 boxes sales to the community pharmacies from pharmaceutical wholesales. It is a huge number, and this number is only one brand name, which is most known and most prescribed drug. We don't know the other generics. Our clinical observations suggested that ornithazole was one of the main causes in DILI cases hospitalized in our center, which is a tertiary transplant center. More than 1,000 liver transplantation has been performed so far. In this study, we aim to analyze the characteristics and outcomes of patients who diagnosed with ornithazole-related DILI alone or in combination with other drugs over the 10-year period. In method, we analyzed the inpatient records from January 2010 through December 2019. Diagnosis was based on detailed clinical history together with liver biochemistry, imaging, and in some cases, liver biopsy. Main inclusion criteria were the absence of confounding disease, especially for acute viral hepatitis, and the exclusion of other diseases, including autoimmune hepatitis, metabolic liver diseases, and biliary obstruction. So the evidence of the absence or minimal alcohol consumption is a main inclusion criteria. In results, 24 patients were identified, which represents 15% among all DILIs. As you can see, most patients were female. Mean age was 45, and some patients have several comorbidities, including diabetes, hypertension, and others. The median duration of hospitalization was 13 days, and the most reported symptom was jaundice, which about 70% of patients suffered. You can see the other symptoms here. In patients who had available data, the dose within the range recommended in most patients, the median duration of therapy was 5 days, ranged 1 to 30 days. The median latency time was 6 days, ranged 1 to 21 days. Ornithazole was used alone in 8 patients, which about 1/3 of patients. or in combination with other drugs, especially with amoxicillin clavulanate in remaining patients. You can see the other drugs in here. In lab values are shown here at admission or peak and final levels. As you can see, the median levels of transaminases were highly elevated, up to 5,000, and median bilirubin level was 21 milligram per deciliter and reaching up to 35, and median INR level was 1.6. Other labs are shown here. No significant change was observed in creatinine levels. For viral and autoimmune markers, all patients were negative for hepatitis B and C. Antinuclear antibody was 1 to 160 in one patient and weakly positive in 2 patients. All other viral and autoimmune markers were negative in patients who had available data. Pattern on liver injury, as described by T2 alkaline phosphatase ratio, was mostly hepatocellular, and minority of patients has cholestatic or mixed pattern. Pathology was available in 11 patients, and several histological features was observed, including confluent necrosis, PPS-like cholestatic pathology, acute hepatitis with several features, as you can see here. And massive necrosis is prominent in explanted liver in patients who had undergone liver transplantation. For treatment, an acetylcysteine was given to all patients. As you can see, 1/3 of patients received prednisolone, considering that drug-induced autoimmune hepatitis or immune-mediated DILI was probably suggested in this patient. Plasmapheresis was performed in 2 patients. In outcomes, 19 patients were discharged. However, 5 patients, which means 20% of patients developed liver failure with severe outcomes. 3 patients underwent liver transplantation. 2 patients died without liver transplantation, and 1 patient died after liver transplantation. We performed univariate and multivariate logistic regression analysis to predict worse outcomes. As you can see, INR, bilirubin, and albumin levels were associated in univariate analysis. However, only final INR level remained significantly in multivariate analysis with high odds ratio. So we constructed a prognostic index to predict outcome. In this formula, values more than this cutoff can predict the outcome with high sensitivity, 100 specificity. In conclusion, there are several reports demonstrated ornithazole-induced liver injury. Interestingly, all these reports are reported from Turkey, as you can see here. Some of them are here and here. And Dr. Müjdat mentioned at previous session, this is one of the most important DILI series in Turkey, which was reported by Dr. Edelman and colleagues, which was published in 2010. And as you can see, the metronidazole and ornithazole was the most common second agents among antibiotic drugs in this DILI series. And very few studies from the other countries have been described ornithazole-induced liver injury. This study from China and this study from Belgium. However, none of these studies reported severe outcomes such as death or liver transplantation. In conclusion, our study shows that ornithazole alone or in combination with other drugs can cause severe outcome, and that INR level may predict poor outcome. Why is our population susceptible to ornithazole-related DILI? We don't know the answer of this question now, but genetic predisposition may play a role. Obviously, we need more study to explore this. Lastly, I think this collaboration will continue to strengthen in the future. Thanks for your attention.
Thank you, Dr. Turan. This was a very interesting and very nice presentation. We move on with the next case report, and that's going to be by Dr. Edmund Aithal, and it's going to be entitled Dilemmas in DILI.
Good afternoon, everyone.
Good afternoon, everyone, and thank you for the opportunity for me to present
one of
this
the
case.
research fellows in hepatology in Nottingham. So this case has challenged us. She's a 64-year-old Caucasian female with a past medical history of reflux disease, glaucoma, hypertension, and high BMI. She's an occasional drinker and non-smoker with no previous allergies. She was admitted to hospital in September 2019 following feeling generally unwell and anorexic, and they referred her to us with suspected drug-induced liver injury. And at the time, the suspected medications were ranitidine. They were given from 22nd of August till 4th of September when she was admitted, and erythromycin that was given over a 2-day period from her GP for ongoing diarrhea. So she's also been on a long-standing medications, including latanoprost, tibolone, which is a part of a hormonal replacement therapy for postmenopausal symptoms, omeprazole, and perindopril. She hasn't taken any over-the-counter medication or no herbal remedies that could have triggered that liver injury. So her liver biochemistry on admission, she had a hepatocellular liver injury with ALT over 1800. Her bilirubin and alkaline phosphatase were normal. She had preserved synthetic function, and her clinical examination was unremarkable. She had no peripheral stigmata of chronic liver disease and no signs of acute liver failure. Her imaging also showed some fatty changes in the liver. The common bile duct was normal with no biliary duct dilatation, and she had some gallstones in her gallbladder. We have done a full liver screen, and her virology screen was negative apart from previous exposure to EBV. Her immunoglobulins were within normal limits, and her autoantibodies were negative apart from positive P-ANCA. So when I first saw her, the first thing is to try to determine the date of onset. And going back, I've noted that the ALT was elevated on 21st of August prior exposure to both medications. So she came into emergency department with diarrhea on 21st of August, and her ALT was actually 851. They have switched her omeprazole to ranitidine because of her diarrhea, and her GP gave her erythromycin for her ongoing symptoms. And then a few days later, she came to us with worsening of her liver injury. So this is just to summarize and to show that the date of onset was prior exposure of ranitidine and erythromycin, so they cannot be responsible for her liver injury. Following up her liver biochemistry, as you could see, her ALT has improved dramatically. However, it has plateaued. Her ALT and AST, they're both over 5 times upper limit of normal, and her alkaline phosphatase and bilirubin remained within normal limits. So that prompted us to request a liver biopsy, which showed some portal inflammation with plasma cells, eosinophils, and neutrophils, in addition to lobular inflammation and granuloma formation. There were no interface hepatitis, there were no established fibrosis, and the conclusion from the liver biopsy that these features are more likely to be drug-related rather than autoimmune hepatitis. So going forward, in 6 months down the line, her transaminases remained elevated. She had occasional abdominal pain, which prompted more investigation to rule out any biliary pathology that could have been causing this. And her MRCP was unremarkable, with no normal CVD and no intrahepatic duct dilatation. They had commented on a slight irregularity of bile ducts, which prompted an endoscopic ultrasound, which ruled out any biliary pathology. We thought about seronegative autoimmune hepatitis at some point, and the HLA DRB1, 0301 and 0401 were negative. So it was just a time to reflect and see all the investigations that we've done so far, and that might also highlight the limitations of our tools to give us the right diagnosis in these challenging cases. And it was time to do a consultation, and before we call the patient, after 6 months of her ongoing liver injury, start to think of the differential diagnosis. So we had thought of seronegative autoimmune, and we thought if trial of steroids would be beneficial or would be sensible at that point. She had been on 3 drugs over a 5-year period, so ongoing DILI was on other possibilities. And we thought about a liver biopsy if that would give us some extra information. And then I decided to take the history again, and she told me that the dose of tibolone has changed over the years, and she's been taking it between once a day to 3 times a week, which doesn't necessarily reflect or cause her liver injury, but from the 3 drugs that she's been exposed to, that was the most likely that could have triggered this. And we decided to stop the tibolone despite a hesitation from the patient because she had severe postmenopausal symptoms. And the next slide shows you that following stopping her tibolone, her liver biochemistry completely normalized. So the ALT and AST have normalized completely. And to look back at the literature to see what the available evidence for tibolone-induced liver injury, it is a hormonal replacement therapy. It is a nortestosterone derivative with weak androgenic effect and synthetic steroids, and extensively metabolized in the liver. So according to LiverTox, it does cause an increase of the transaminases with over 3 times the upper limit of normal, but clinically apparent DILIs were not reported. And after clinical use in Europe, they have reported cases of DILI, but they're mainly 6 to 12 months following starting the drug, which fits with our hepatocellular pattern, similar to this case, and they were self-limited after withdrawing the drug. There are 3 case reports in the literature of tibolone DILI, with the longest latency period is actually reported in Turkey with over 5 years of exposure. And just to summarize and reflect on this case, the learning point is that, as we know, diagnosis of DILI is challenging and can be easily missed. And to try to determine and assess causality, defining a clear time of onset of the liver injury and detailed medication history are key. It does highlight the limitation of our diagnostic tool to diagnose DILI as they lack the specificity. DILI can occur after a prolonged period of exposure, even in medications that we have a very limited knowledge of its hepatotoxic potential. So keeping an open mind in these challenging cases is really important. Thank you very much for listening, and I'm happy to answer any questions. Thank you.
Thank you, Dr. Aithal. That was a really very interesting case. I learned a lot. It's confusing a little bit as well. Dr. Guru, do you want to announce the next speaker, or should I do it?
Oh, you're welcome to introduce Fulya.
Okay, the next speaker is Fulya Günçer from Ege University in Izmir, from the gastroenterology department. Her topic is drug-induced autoimmune hepatitis. So again, a summary of what we are talking about probably.
Dear colleagues, my topic is drug-induced autoimmune hepatitis. My topic is drug-induced autoimmune hepatitis. As mentioned, the idiosyncratic drug-induced liver injury is a major cause of acute liver failure. Liver cell damage may trigger, resulting in B-cell mediated autoantibody production and cytotoxic T-cell responses. Autoantibody positivity and elevated IgG levels are not uncommon in DILI. And this may cause the diagnostic confusion. Is it really DILI or autoimmune hepatitis or drug-induced autoimmune hepatitis? The drugs can cause classical features of autoimmune hepatitis in 9% of patients. This situation causes the challenge for diagnosis of both clinical scenarios. Minocycline and nitrofurantoin are implicated in 90% of cases. There is female predominance, and majority of patients are acute onset, and up to 30% of the cases are with hypersensitivity reaction, and absence of cirrhosis at presentation is an important clinical manifestation. You can see here in two tables and potential drugs related to autoimmune DILI. There are a lot of, but the most known of them, minocycline, nitrofurantoin, methyldopa, and hydralazine. But there are many others. You can look at these tables for the risk. Not only the drugs, dietary supplement can cause autoimmune hepatitis also. In this paper, there is a case report. It is interesting because this patient's turmeric dietary supplement was not documented in patients' medical records, and positive role of the turmeric supplementation was ultimately identified by the patient rather than the healthcare providers. So the clinic history should detail all previous exposures to drugs and supplements. For this scenario, the latency interval is ranges 1 to 8 weeks to 3 to 12 months, usually more than 6 months. And nitrofurantoin and minocycline, it usually exceeds 12 months. There are nearly 3 potential relationships between autoimmune hepatitis and DILI according to Aithal guidelines. The first one is autoimmune hepatitis with superimposed DILI, pre-existing chronic autoimmune hepatitis with additional DILI insult, and DILI-induced autoimmune hepatitis drug intake triggers an immune process which leads to development of chronic autoimmune hepatitis, and long-term immunosuppression is usually required in this group. Immune-mediated DILI is some difference because it is not really autoimmune hepatitis. in this situation, drug intake triggers autoimmune hepatitis, and after drugs exposure, spontaneous remission, and steroid withdrawal. How about the mechanism of injury? In fact, there is a similar pathologic mechanism between DILI and autoimmune hepatitis. In fact, there are two differences. One is the antigenic difference. In autoimmune hepatitis, usually self-antigens. In DILI, drug or its metabolite or drug and protein adducts are the antigenic determinants. And the second difference is in autoimmune hepatitis, antigenic determinant is causing stimulation to the immune system constantly. But in DILI patients, this antigenic stimulation is during the drug using. As you know, hepatocyte can metabolize drugs and form drug protein adducts, which may be immunogenic. And these newly formed antigens may in turn incite CD4 and CD8 cytotoxic lymphocytes and natural killer cell proliferative responses. The drug metabolizing enzymes are likely targets for neoantigen formation, and sometimes drugs may interact with T-cell receptor directly, and probable genetic predisposition can be effective in this pathologic mechanism. Molecular mimicry also is important, and it acts as a possible key element for microbiome-associated and drug-induced intestinal autoimmunity. Diet or antibiotics can cause the change in composition of microbiome and may lead to increased intestinal permeability and transition of bacteria into portal circulation, and this facilitates the immune-mediated liver inflammation. How about the genetic testing? Guru told very perfectly before this section. Candidate GAN studies initially and genome-wide association study more recently have identified several genetic factors associated with DILI, and there are over 15 currently used drugs where HLA genotype or haplotype increases the susceptibility to DILI. A specific HLA allele that has been linked with hepatotoxicity to a particular suspected drug should equally support the diagnosis of DILI. In this table, you can see the autoantibodies in first part. As you can expect, autoantibody positivity is more common in autoimmune hepatitis patients than in normal, and HLA types and risk alleles you can see here. In DILI cases, they are more common than the normal population, and there are some specific risk alleles, and you can check these alleles if your laboratory is suitable for these studies. What about the symptoms? The onset is typically insidious, extrahepatic manifestations such as rash or joint pains, and symptoms of hepatic injury, fatigue, nausea, poor appetite, and jaundice arises late and may follow several months of non-specific symptoms. And we can see a picture like acute viral hepatitis, and acute chronic phenotypes may overlap. For the laboratory, moderate serum ELT and ESD elevations and minimal increase in alkaline phosphatase levels and serum autoantibody positivity and IgG levels and total globulins often but not always raised. Autoantibody titers and immunoglobulin levels also decrease with recovery, but low levels of autoantibodies might persist long-term. There's a paper from Bohr et al. About the features of autoimmune hepatitis in patients with DILI. Their aim were prevalence and clinical relevance of autoimmune phenotype in cohort of patients with DILI and the association of liver injury with and without autoimmune features with typical autoimmune HLA alleles. There were 88 cases and 80 of them were women. A total autoimmune score was calculated. Some of antinuclear antibody, smooth muscle antibody, and soluble liver antigen and IgG scores, and patients were considered to have an autoimmune phenotype if the total score is equal to 2 or above 2. The latency period for nitrofurantoin and minocycline more than a year. In contrast, for methyldopa and hydralazine, all were within 1 year. Liver injury was predominantly hepatocellular in this cohort. A phenotype of autoimmunity was 82% of cases due to nitrofurantoin and 73% of cases due to minocycline and 55% of cases due to methyldopa. And similar percentages of patients with DILI have HLA-DRB10301, HLA-DRB10401. It is similar to S control. As you know, these alleles are associated with autoimmune hepatitis, but in DILI patients, the positivity of this allele is not different from the controls. And 25% of the patients had severe injury, with majority of them secondary to nitrofurantoin. When you look at this slide, you can see the baseline and follow-up autoantibodies and IgG levels of the patients in that study. You can see that decreasing during follow-up. The immune response is decreasing after the event. There were 2 deaths and 3 transplantation in nitrofurantoin injury and 1 liver transplantation in hydralazine group in that study. For this study, most cases of DILI attributed to nitrofurantoin or minocycline have a phenotype of autoimmunity similar to autoimmune hepatitis. These features decrease with recovery of the injury. They are not associated with typical HLA alleles for classic autoimmune hepatitis, and autoimmune type DILI responds to withdrawal of drug and seldom reach the stage of SELF. Despite the overlapping features of between autoimmune hepatitis and DILI, a liver biopsy can be useful. Portal inflammation, absence of fibrosis, portal neutrophils, plasma cells, and intracellular cholestasis are more suggestive of DILI than autoimmune hepatitis. Histopathology of drug-induced autoimmune hepatitis, in fact, is similar to classic autoimmune hepatitis, except the absence of advanced fibrosis or cirrhosis in most cases, and central lobular zone 3 necrosis may be present, and bridging fibrosis is rare. There is a paper about the histopathologic analysis of autoimmune hepatitis with acute presentation, differentiation from drug-induced liver injury. You can see here baseline characteristics like autoantibody positivity, IgG levels, and autoimmune hepatitis score. As expected, they are more prominent in autoimmune hepatitis group. When you look at this slide, you can see some characteristics of autoimmune hepatitis, like rosette formation here, plasma cells, many, and rosette formation and cobblestone appearance is quite pathognomonic for autoimmune hepatitis patients. When they compare the histopathologic characteristics in 2 groups, lobular necrosis, cobblestone appearance of hepatocytes, plasma cell infiltration, central lobular fibrosis, hepatic rosette formation, like other portal characteristics, are more prominent in acute presentation autoimmune hepatitis. So liver biopsy can be helpful to differentiate the diagnosis for this patient. If we have a patient and we are suspecting having DILI, if this patient has a positivity of autoantibodies and high immunoglobulin levels and carriage of specific alleles, as you can see here, which is associated with autoimmune hepatitis, our diagnosis changes to autoimmune hepatitis for this patient. There is another study about the differentiation characteristics in drug-induced autoimmune hepatitis. There were 12 drug-induced hepatitis patients here. 67% of patients due to the nitrofurantoin. And in these patients, none of the patients with drug-induced autoimmune hepatitis had cirrhosis or developed it during follow-up, but it was present in 42% of autoimmune cases at diagnosis. This is an important characteristic to differentiate these patients. And early ELT response to corticosteroid treatment distinguishes idiosyncratic drug-induced liver injury from autoimmune hepatitis. There were 22 patients in each group. The first one is DILI with steroids, and the second one, autoimmune hepatitis with steroids. You can see the initial diagnosis and final diagnosis here. They had 5 misdiagnoses in this group, and they checked the ELT response after corticosteroid treatment. You can see here, DILI patients has an earlier response to the corticosteroid therapy, a 9 reduction in ELT levels per day during the first week of treatment discriminated DILI from autoimmune hepatitis with 83% sensitivity and specificity. When we check the clinical course, in autoimmune hepatitis, you can see some like these fluctuations. But in DILI patients, you can see only one peak, only one attack, because the drug is stopped. If you don't use the drug again and again, you can see the only one peak like this. But autoimmune hepatitis, as I mentioned before, antigenic determinant is constantly stimulate the immune system, so you can see some fluctuations like this. How can we treat these patients? We must discontinue of a funding drug, and we can wait the resolution within 1 month, rarely 3 months. We can use N-acetylcysteine or ursodeoxycholic acid. The other important question is, why should we institute glucocorticoid therapy for drug-induced autoimmune hepatitis? We can answer it according to HALO. Serum aminotransferase levels more than 3-fold upper of limit normal, and total serum bilirubin more than 2-fold upper limit of normal. If this patient has this characteristic, the risk of death or need for liver transplantation, nearly 10% of patients. If liver histologic features cannot establish drug etiology with certainty, and if symptoms on laboratory tests fail to improve or worsen after 1 to 2 weeks of discontinuation of a funding drug, if there is any evidence of hepatic failure, we can start prednisolone therapy 20 to 60 milligram per day. In mild disease, we can use 20 to 30 milligram per day. Once remission has been achieved, withdrawal of immunosuppression and close monitoring would resolve the diagnosis in majority, because as drug-induced autoimmune hepatitis do not relapse over a follow-up of 3-4 years. But the patients with idiopathic autoimmune hepatitis relapse 63% of cases in 1 year. Timing on withdrawal of immunosuppression varies between clinicians and clinical scenarios, but usually in 6 months after remission. if we have the risk of SCLF, we must be quick, and prolongation of ENR and deepening and jaundice could be precursor of the SCLF, transfer to a higher level of care for consideration of transplantation. And there is an important table here, features of the drug-induced autoimmune like injury and autoimmune hepatitis. The most important thing is in drug-induced autoimmune like injury, majority of them acute onset, not more than 60%, and cirrhosis at presentation is rare, and relapse after drug withdrawal rare, and progression to cirrhosis is very rare. It is the Chia's algorithm. I can say for this important thing, if you see the relapse after corticosteroid therapy, you can say this is a classical autoimmune hepatitis. This is a simpler table about the algorithm. After the corticosteroid therapy, if you get response, you try to taper steroids. If you see the relapse, you can say this is definitive autoimmune hepatitis. If no relapse, you can say DILI. If you don't have the get response, it is another diagnosis. In conclusion, there is no diagnostic test to reliably differentiate DILI from autoimmune hepatitis in the setting of hepatitis. After cessation of steroids will uncover correct diagnosis, autoimmune hepatitis with relapse. In DILI, liver enzymes will stay normal if causative drug has been identified and stopped. Liver biopsy could be useful to differentiate of diagnosis. HLA genotyping can be used to support diagnosis of DILI due to the specific drugs, and DILI rarely causes liver cirrhosis, while symptoms like fever, rash, eosinophilia are unusual in autoimmune hepatitis. This is Professor Andrew Burrows. I was a research fellow of him in 2001 in Royal Free Hospital. If he was alive, he would be with us. I appreciate him, and I want to remember with respect. And thank you for your attention and to be with us. And many thanks to BASL for the cooperation.
Thank you very much, Fulya.
Yeah.
Thank you very much, Fulya, for an excellent presentation and reminding us about Royal Free and Andy Burra. Now we move on to a next speaker from Royal Free, who did genetic studies before I was completing my studentship. So the first citation I had in my first slide was a paper between Marsha Morgan and Dame Sheila Sherlock. So Marsha has been working on complex traits and genetic susceptibility for a long time. She also reported some interesting herbal toxicity in UK. So she's going to talk about herbal and supplement-induced liver injury.
I'm delighted to have been invited to this joint meeting of the Turkish and British Associations for the Study of the Liver, and to talk to you this morning about liver injury from herbal and dietary supplements. The worldwide market in these products is booming. They promise to revitalize, replenish, and reinvigorate us, but the health benefits they claim are largely unsubstantiated by scientific data. And there is increasing concern about reports of hepatotoxicity associated with their use. So let's look first at the products and who and why they're being used. They can range from simple natural herbs down to complex concentrates and metabolites and extractions of vitamins, minerals, amino acids, and botanicals. They're used generally by two classes of people: the well user, who wants to preserve or promote their health, and the ailing user, who wants to achieve better health. The supplements are then used to either add to or replace prescribed medications. They're used for every conceivable problem, from weight loss to depression to arthritis, and performance and appearance enhancement. The popularity of these products is undeniable, and it's big business. The revenue of $36 billion each year in the United States. We don't have exact figures on usage, but it's estimated that 20% of Europeans and some 50% of Americans regularly use HDS. Of interest, in a number of series, it's been noted that up to 75% of cancer victims will use supplements to boost their immune systems. And patients with liver disease are not exempt, as was shown here in the HALT-C trial, where the organizers were really surprised to find that up to 40% of the patients enrolled for antiviral therapy against hepatitis C were taking herbal preparations. The one most commonly used was silymarin or milk thistle, which is reported to have beneficial effects on liver health. So it's a real concern that patients who already have liver damage are being exposed to compounds with potential hepatotoxicity. One of the major problems is the regulation or lack of regulation of these products. So there's no global consensus on the definition or categorization of the products, so they can be treated differently in regulatory systems across the world. They are, however, generally classified as supplements and as such are regulated as foods. There are various food acts, but these are very weakly enforced. Manufacturers have to ensure the identity, purity, strength, and composition of their products, but there's no compulsion on them to prove safety or efficacy. And the addition of unlabeled ingredients is a significant problem. This was addressed by Navarro and the US DILI network when they collected all the HDS products from their enrolled patients. Those that had labels of ingredients were chemically analyzed, and they were also assayed for known hepatotoxins, including pharmaceuticals. Now, what they discovered was that 80% of the products were labeled, 20% were not, but of those that were labeled, 51% were mislabeled. And of the 140 mislabeled products, they lacked at least one of the listed ingredients. So compounds that were supposed to be there were not. Of greater concern, however, was that in 40%, there were unlisted ingredients. Anabolic steroids added to performance enhancers, tamoxifen added to bodybuilding compounds, and diclofenac to the arthritis compounds, so no wonder they worked. Thus, this lack of stringent regulation means that consumers are being exposed to compounds whose biological effects are largely unknown, to unlabeled ingredients added intentionally, such as synthetic or illicit anabolic steroids, and unlabeled ingredients added accidentally or as byproducts of the manufacturing. So let's look now at what we know about the epidemiology of HDS-related hepatotoxicity. We didn't know much about the epidemiology of usage. We know far less about the outcomes. Some published data are available from DILI registries in Spain and the US. There are numerous case reports, case series, and systematic reviews, but a lack of population-based surveys. The one that is always quoted is the Bjornsson 2013, which was based in Iceland. During the study year, the incidence of DILIs there was 19 per 100,000 persons. Of these, 16% were attributed to HDS. Therefore, the extrapolated incidence of HDS-related hepatotoxicity is low at 3 per 100,000 persons. So what can we garner from the registries? Well, the Spanish DILI registry was established in 1994. It's ongoing and prospectively identifies cases. The latest publication in Press with J. Hepatol, Stevens 2021, provides information on 843 enrolled cases. The proportion attributable to HDS has increased over 20 years from 1.5 in 1998 to 6% in 2019. The signature of the HDS hepatotoxicity is as follows. There's a female predominance, invariably hepatocellular injury. Evolution to ALF is commoner than with the drugs, and re-challenge, intentional or otherwise, is more likely. This database is expanding now to encompass Spanish-speaking countries in Latin America, and preliminary data from there shows that the prevalence of HDS is very much higher, but the signature is similar, and we look forward to ongoing information from that extended database. Data are much less easily accessed from the USA DILI registry. They don't have such consistent reporting. Data has been available since 2004, and Navarro in 2014 produced an analysis of 839 cases that had been enrolled up to 2013. The total attributable to HDS was about 15.5%, so considerably higher than in the Spanish registry. But that's because we have this separate category for the bodybuilding compounds, which are obviously being used much more extensively in the United States than elsewhere. The proportion of cases attributed to HDS has increased from 7% in the first year up to 20% from the latest data, and I gather that that is remaining the same at about 20%. The signature of HDS is dual-fold. The bodybuilding HDS, which we suspect almost invariably contain anabolic steroids, are young men presenting with a cholestatic picture, prolonged jaundice with a median of 91 days, but no deaths and no needs for transplantation. The other HDS, signaturing, reflects that in the Spanish DILI database, predominantly middle-aged women, hepatocellular injury, and a greater requirement, severity of disease for transplantation. Here we see the comparison of outcomes between these other HDS and medication. No real difference in all-cause mortality, 4% against 7%, but a very definite and significant difference in the need for transplantation. All of the women that were transplanted with relationship to HDS were of non-Mexican white origin. Moving now from the west to the east, we might expect that the prevalence of HDS hepatotoxicity might be higher. And this is because traditional medicines, including HDS, are integrated into many of the Asian healthcare systems. But despite the fact that there is similar widespread use of traditional medicines across the region, there are startling differences in the proportions of liver disease ascribed to HDS, which is shown on this figure. So if we look at the relative prevalence in Japan and China, it's about 17–18%, but in Singapore and Korea, over 70%, while India at the bottom of the league there at 2.5%. And those Indian cases have all been ascribed to Ayurvedic medical products obtained from the internet, and contamination of those products with arsenic, mercury, and heavy metals has been shown. So why we see this picture is unknown. It could be differences in reporting, that's unlikely. It could be differences in population susceptibility, that's a possibility, but it's intriguing and it certainly needs further exploration. We saw from the DILI registries the signatures that have been seen in patients who are actually presenting with clinical illness, but what about the spectrum of injury overall? Well, that is the same as for any DILI. You have the full spectrum from acute hepatitis through to cirrhosis. You have hepatocellular and cholestatic injury. Some of the products actually have a defined signature. So we see here Cascara, for example, bridging fibrosis with massive bile duct proliferation, Germanda often with chronic hepatitis and cirrhosis, mistletoe, some of the most florid cases of acute hepatitis. So there are some signatures related to some of these compounds. The fact that in the registries we saw the outcomes in the HDS patients, particularly those with an acute hepatitis as being more severe, was picked up by the US Acute Liver Failure Study Group. And they looked at all the cases that had been referred to them with acute liver failure between 1998 and 2015. Of those, DILI constituted 10%. In the first half of the study period, HDS made up 12.4% of those DILIs, whereas in the second half, they accounted for 21%. And as we saw from the registries, in the HDS population, there were significantly higher transplantation rates and significantly lower 21-day transplant-free survivals. So again, we're having evidence that the proportion of cases coming forward ascribed to HDS is increasing and that their outcomes are significantly worse. Now I just want to round up by giving a couple of selected examples of products where we have much more information about causality and can feel much more secure about ascription. The first of these is green tea extract. Now, this is not the green tea that you all drink and love, but a complex polyphenol extract of green tea. It's included, as far as we know to date, in over 100 OTC herbal preparations and has been implicated in over 100 cases of hepatotoxicity. The picture is one of acute hepatitis going on in some instances to fatal acute liver failure. Recently, of interest, the hepatotoxicity has been associated with a specific HLA allele, suggesting that there is, at least in part, an immunological etiology. But we also have a randomized controlled trial that actually proves, to at least injury degree, that green tea can be associated with damage. This is the Minnesota Green Tea Trial. This was instigated because of reports that this green tea extract might be beneficial in terms of preventing cancers, liver and breast. So they set out to have a look at the effect of high doses of GTE on biomarkers of breast cancer in over 1,000 women who were postmenopausal and disease-free on admission. During the trial, they found that those treated with the extracts were 7 times more likely to develop a transaminitis. This disappeared when the product was stopped and reappeared when the product was restarted. So there we have evidence that green tea extract can be associated at least with a transaminitis, and undoubtedly the reports of acute liver failure follow on from this. The second product I wanted to look at, where we have very firm evidence of causality with liver injury, is the natural leaf product of the evergreen plant Cathas edulus. This is known as CAT, although it is also known by a number of other names that you see in the left-hand panel. It's native to the Horn of Africa and the Arabian Peninsula, and it's chewed for the stimulating effects of the contained cathinone. Globally, it is estimated that cat is chewed regularly by some 20 million persons. Here are pictures of the cat fields in Africa, where it is actually harvested and produces a vast income for the countries concerned. The leaves and the shoots are collected, and then they are chewed in these social gatherings called marfresh that take place every day, where in this instance you can see men gather, chew on the cat and chew on the cat. However, it's also being used by the wider diaspora and extensively so, despite the fact that it is banned in most countries in the world. In the UK, for example, you can buy a bunch of 25 twigs from street markets or mobile traders for as little as £4. The contained alkaloids, cathinone and cathine, are the active ingredients. They have a very short half-life, are cleared from the system within 24 hours. Cathinone has the same configuration as amphetamine and also very similar to the illicit drug ecstasy. The first inkling that we really had a problem with cat came from a series that we observed at the Royal Free Hospital in London, where over 18 months we admitted 6 Somali and UK residents with severe acute hepatitis, resulting in death or the need for transplantation. These were extensively investigated, but no cause was found except for the fact that they regularly chewed cat. We were able to prove for various reasons the causality, both in terms of the temporal change and re-challenge, but finally nailed it when we were able to demonstrate very high concentrations of cathinone in explanted liver in a person who had not been exposed to the drug for at least 6 weeks. So drug accumulation may be a very important factor. We followed this up by actually moving to Ethiopia and undertaking studies there with a Norwegian field team because people were doubting that the cat was causing this much problem because they weren't seeing cat-related liver injury in the countries where its use is so prevalent. However, we discovered first off that over 55% of the cases of chronic liver disease in Ethiopia do not have an ascribed cause. It was thought that hepatitis B, hepatitis C would be prevalent, but they only accounted for about 45% of the cases. So we then undertook a case control study of 150 patients with cirrhosis and 300 controls. And what we were able to show is that the risk of developing chronic liver disease in men increased with exposure to cat and increased dramatically as the dose that was consumed increased. So a dose relationship there also, but we found nothing in the women. So at the present time, while we can say that the cat-related hepatotoxicity is likely to become a major public health issue with far-reaching consequences, we need to determine the factors behind the individual susceptibility. We're currently undertaking a GWAS, and that striking sex-related difference also needs explaining. So finally, in this field, what are our pressing needs? There's irrefutable evidence of the risks associated with use of these compounds. There needs to be increased awareness, and education is essential. But patients should always disclose their use to their doctors, and physicians should always inquire of their patients whether they are being exposed. We need harmonization of the regulations governing these products. The health claims should carry a burden of proof. We need more rigorous scrutiny and increased quality control of the products, and more rigorous prospective collection of data, not only on HDS hepatotoxicity, but DILI in general. And I was delighted to hear Jane speak about the Pro-Euro registry and our Turkish colleagues about their database. Finally, I would like to leave you with these 4 websites where if you have any queries about these products and want information about them, it can be reasonably, easily, and reliably accessed. Thank you very much indeed.
Members of the panel, so that we can answer some questions.
We invite them to the podium.
Yeah, they're all here. I can see all of them here. Dr. Yurdaydın, you can ask questions. I'm just picking up from the site. One of them was about the pattern of liver injury and its discordance with histology. William, is there, what do you feel about discordance? do you feel pattern of liver injury is good enough, or you feel it's being used for all kinds of liver disease rather than just acute liver injury?
Yeah, I mean, that's a good question. I mean, there is discordance. We see it. We see ALTs of 400, 500 and not much going on biopsy. In fact, I had a patient on vedolizumab recently with exactly that situation. So I guess I don't know whether the histology in that case supports DILI or refutes it. I don't know that there's been an awful lot of good research looking at that aspect, to be honest.
Yeah. I had one patient with infliximab, you just remind me, was similar, clear-cut DILI. Patient had infliximab DILI, stopped the drug, and then had adalimumab, still had another DILI. Then we did a biopsy. It improved after withdrawal, but not a lot to show in terms of inflammation. Do you have any speculation of what might be the explanation?
No, it surprised me to see such a normal looking biopsy for such a high ALT, but we do sometimes see that in other contexts as well, biliary transport defects, that sort of thing. So I guess histology and biochemistry don't always match, and that's similar to a lot of medicine, I guess.
Can I ask you, would you expect to see, if we had a second biopsy done, I mean, at the same time, at two different places of the liver, would you see the same? So could there be a sampling error issue?
I don't think so. No, I think histology does its thing and biochemistry does its thing, and they sometimes correlate, but I don't feel that there would have been a sampling issue because it was it's a decent sample.
Yeah.
Okay, thank you.
I don't think that would be likely, to be honest.
Yeah.
Any other thoughts from the panel, Marsha?
No, I mean, I think you see this, not just with DILI, but you do see it with other conditions as well, that you have this discordance. You either get more than you're expecting from the biochemistry or you get less. So I think it is not just with DILI. I think you do see discordance with non-DILI as well.
Okay. Second question was for me about onidazole-induced liver injury. Genetic susceptibility query. I'll ask Marsha about that.
Difficult to say. I mean, you popped a question in, could this be HLA? Could the question was raised as, is this something specific to the Turkish population? And I think that's possibly worth pursuing. But, none of this is terribly well documented anywhere. And it might just be worth seeking, direct evidence from other countries as to whether or not they're seeing this. So those would be
Yeah, when I was seeing the presentation, I had a question actually for Turkish colleagues, is that whether there is any reason why onidazole is more used in women. I saw your case series had 80% women. That made me think of HLA, but at the same time, some drugs are more used in women than men. Is there any explanation for that?
Maybe this is related to gynecologist received, because maybe it could be, and maybe the autoimmune response, it can be related.
So given by gynecologists, that makes sense.
Mainly, and the dentists.
Dentists, okay. That shouldn't be female predominant. I think pelvic inflammatory disease, is that when it's given?
Yes, they usually.
Okay, got it. At
But
least
before finishing the onidazole business, what about onidazole hepatotoxicity in England?
We don't have that drug. We don't get that drug, you see. We only have metronidazole.
Oh, I see. You don't have onidazole. Okay.
No. I just first time heard from Mujdat.
Okay.
But you've got a good collection of cases. It's worth, I just asked in the chat box whether you have DNA for them. We can certainly type them.
Yeah.
Yeah, so next question. I think it's open. Maybe
Yes.
Asking whether there is any marker that determines disease outcome after hospital admission. In other words, patients admitted with DILI, for example, what identifies the outcome looks like the tone of the question. So open question, anyone can pick up and answer.
ENR is the most important laboratory test, I think, for these patients.
Okay. Anything else? Any other markers?
And bilirubin for the DILI.
Yeah. I think William talked about Hy's law, a new Hy's law. William, would you like to elaborate?
But I don't know that there's anything specific for a patient, on discharge, if you like, other than these various prognostications, most of which include bilirubin, INR, etc. So, yeah, I mean, I think all those predictive formulae apply.
Okay. There's a publication in circulation. I hope it gets in. Then I can say it might be in Journal of Hepatology, looking at a modeling called accelerated survival time. So it's a proper statistical way of getting the trajectory of recovery of patients with liver injury. So if it gets in, that will be probably first time there's been a proper, thoughtful modeling of it. And they used 2 cohorts. One was idyllic. That's why I got to know our cohort, our data was stored. It's available publicly. They used that data. Then they validated in liver tox database. And then they went on and validated in Spanish registry. So if it comes out, there will be an app with it, and you can put in the numbers and then find out what the trajectory of recovery is. I mean, for the first time, they have not come up with a cutoff. We all like cutoffs, but cutoffs is not how the life goes and comes. So they have given, that gives a trajectory. So you put in a number, it'll come up with a graph of what the likelihood of improvement is in a given period of time, something along that line.
Can I ask about cutoffs? Speaking about cutoffs, Dr. Zeybel asked to Dr. Aithal a question. And the question is, do you think that the 8 to 12 week cutoff for DILI latency is arbitrary and needs to be reconsidered?
I think it's a very good question, and it just highlights sometimes our own cognitive biases, because because with most drugs the DILI is within 3 months, we presume that this is if the drug is over this period, it is unlikely. But sometimes we don't know the truth. We only know what's available, and it's a very good point to keep an open mind.
Yes. So no strict cutoff time, latency time period is the answer.
Agree.
It's to do with the exposure of the drug. Is it what Mujdat is asking? Yeah. Is it from the time of onset of the drug to the injury? Probably that's what he's asking.
Yes.
Yeah. I mean, you saw, I think, in William's presentation for nitrofurantoin. Is it William's presentation? Nitrofurantoin and minocycline, which actually by rule is after 1 year. Is that right?
It is in my presentation.
Oh, yeah,
it's usually more than 1 year for minocycline and yes.
Yeah. So,
nitrofurantoin.
Yeah. So Tibulin, Edmund, you presented the case. So you said there was something on the literature. What was the latency for that case?
Yeah. So most cases the latency is after between 6 to 12 months. But there was only one case report in Turkey that patient had over 5-year exposure, and that And it just highlights that it could happen. We didn't think about it initially because we thought it's a very long latency, but it just highlights that it could happen. Maybe we are missing DILIs that are subclinical because we presume that it's not likely to be the cause. But there are only 3 case reports in the literature.
Okay. I have one question. I don't know who should answer, but this is the question. Can someone tell something about autoimmune scoring?
About?
Probably about the autoimmune hepatitis scoring system.
I think they want to mention about the autoimmune-induced, drug-induced autoimmune hepatitis. They are not useful autoimmune scoring system in these cases. The other issues I taught in my presentation are more important because there are some acute hepatitis, acute presentation of autoimmune hepatitis usually have low IgG levels and low, autoantibody negativity. So autoimmune scoring system is not very useful for acute presentation in autoimmune hepatitis and drug-induced autoimmune hepatitis. Usually not useful.
And the question was from Dr. Üstündağ, and he had another question, and you're right, it's probably about this, because he asked, how can we differentiate immune-mediated DILI and potential chronic autoimmune hepatitis after DILI?
Immune-mediated DILI doesn't relapse after corticosteroid stopping. But in really classic autoimmune hepatitis, we can see the relapses nearly more than 60% of the cases in 1 year. So if you think about the immune-mediated autoimmune hepatitis with drug-induced, you can stop the steroids after remission. And you can wait and to follow up this patient. If this patient doesn't relapse, this is drug-related and immune-mediated disease, and this is not really autoimmune hepatitis, classic autoimmune hepatitis.
There's a question on ursodeoxycholic acid. What is the evidence base for it, roughly?
Not very much, but sometimes cholestatic types injury, we can use it for the relief of the symptoms.
Yeah, I think those are the ones in the chat. If I can ask a few questions of my own. So ketamine-induced cholangiopathy. William, tell me more about the context in which you see the patients. What kind of patients, what demography, why they get ketamine and how long they get it and things like that.
I mean, I've only seen a few cases. I mean, this one I presented had been using ketamine since the age of 15 as a recreational drug. And similarly, it's a young person who's used it recreationally for a while, a few years maybe. I mean, it seems like you need to take a certain amount over a period of time. I don't know exactly what, scientifically what sort of dosing is required. Does seem to have an element of reversibility, but again, I'd need to look at a bigger series to see, what the potential long-term outcome is in these cases.
And question on your drill tox ALF. I mean, is that a score? And I should probably miss some information you might have mentioned. I mean, how is it useful in clinical practice?
I think it's just another score. It's platelets.
Do you use it for your own practice? I
haven't used it. No.
Yeah.
It may or may not be any better than Hy's law, or new Hy's law. I'm not sure what the consensus is on that.
Do we practically use any scores for transplant listing, for example, for idiosyncratic hepatotoxicity outside paracetamol overdose, idiosyncratic ones?
Well, I mean, I tend to use the King's score. I mean, we have a list of super urgent categories for UK patients, and they revolve around the King's criteria, in terms of drug etiology, non-A, non-B, drug etiology, bilirubin, INR, encephalopathy.
Green tea toxicity. Oh, sorry.
Yeah.
Okay. Marsha, green tea toxicity.
Mhm.
You looked at cathinones in the liver. I mean, what made you think of that?
Well, basically, that's the active ingredient in the cat itself. And while we were, our thoughts were, was it accumulating? Was there a problem with its metabolism? It took a lot to do because cation is a Class C drug, and we did this in Glasgow, but we had to get Home Office permission in order to get the compounds for spiking, with the HPLC. We just wanted to see what we had in the liver in terms of drug. I mean, it was just a question, is there drug in this liver? We had a liver, and it was massive. I mean, the levels were massive. We also had it in plasma as well. And it had been at least 6 weeks since that patient had actually used the CAT. So massive accumulation, and accumulation that we didn't put down to the fact that the liver was failing because it had been 6 weeks before.
Okay. And I remember the drug which I see in the history books called bromphenone or something, which used to precipitate in the liver. So it was probably there in the 1980s, maybe. It was withdrawn.
Yeah. Mm-hmm.
Well, was this precipitating or crystals, or is it just a chemical you found in the kind of lysate?
In the lysate, yeah.
Lysate, okay.
Can I ask a question? I mean, not me, but there is a question on suspected drug-induced autoimmune hepatitis management strategy. Would you stop the drug and wait and watch, or would you start immediately steroids? Which
I told in my presentation, in fact, but I can repeat again. Firstly, we stop the drug. We follow up the patient. If the patient has not improvement after 1 or 2 weeks, or if ELT levels more than 3-fold upper of limit of normal, or bilirubin levels more than 2 upper of limit normal, if the patient has deterioration like prolongation of ENR or deepening of jaundice, we can start corticosteroid, not in the beginning, during the follow-up, if the patient has a worse findings.
Okay.
And maybe the last question. There was a question, again, open question on a description of a patient who had started on metformin. Bilirubin went up, cholestatic pattern, bilirubin of 170, 2 weeks after starting metformin. CBD was a bit dilated, but there were no stones seen on investigation. Has any one of you seen metformin-induced liver injury? How often it is? I don't see anything in my registry. Edmund, do you remember any?
No, I haven't seen
I
any.
don't see.
Turan, Dr. Turan, any?
No, we don't.
No.
No one has seen. So that's the answer. And we
hold on? Can I have one question to Marsha Morgan from Nurdan Tözün, another lady, 2 strong ladies, one from Turkey, one from England. The question is, she liked to talk, first of all, Nurdan Tözün. The crazy use of herbals here is available also here as well. You see lots of toxicities. Is there any reliable resource database to check liver toxicity or interaction with drugs?
I think the websites that I put up on my last slide are actually your best sources. And you can certainly the pharmacopoeias will give you the interactions. I mean, I saw some studies from Turkey where it was Feltigimanda appeared to be the one that's producing the toxicity in the series that have been produced. But the websites on my slide are very good and reliable sources. They'll tell you everything there is known about the drugs. And I think there is a pharmacopoeia as well that will look at drug interactions.
And she goes on to say that I got the answer. Her next chat box message is that, sorry, I got my answer. Must have waited for your last slide, Masha. So you read her mind.
Obviously, yeah.
I have to ask this last thing as well. It's female jealousy. The question was your secret for staying so young and energetic over the
Actually, in herbal supplements.
But can I ask one thing? In the US, there is a big business in the context of medical malpractice, insurance, and so on. So if you diagnose a cancer as functional disease, for example, you are in big trouble as a medical doctor. But there is no penalty for herbal medical sellers. Is that correct?
Absolutely.
Yeah. Do you think there should be a change in laws, or is there anything?
I think they're not prescribed. And I think that's the difference. I mean, a physician.
But you can watch them on TV doing advertisement that this is good for this and that and that and that. Very good.
That's what I said at the end. I think they shouldn't be making claims without a burden of proof. And I think it's going to take a lot to do that. And I think that's because of the regulations. As long as they go on being regulated as foods, we're not going to get that. Some herbal products that make medical claims that actually do have some data behind them have to be registered as medicinal products and have a product license. In the UK, lots of traditional herbal remedies are required to have a traditional herbal registration, but it declaims on there that they're only being used in traditional format. But I think there's an awful lot of work going on now looking at the actual structures of these compounds and what they're made of. And I think we are moving forward in that field, particularly in China. But I think it's a very tricky area. I think there needs to be better regulation, but I don't know that we'll ever be able to actually regulate it to a level whereby we take responsibility.
Okay. Thank you very much. It was very nice. Thank you for all the speakers, for the listeners, and thank you for the moderators as well.
Thank you.
Thank you very much.
Thank you.
Thank you.
See you all again later on.